Welcome to The Explainer. Today we're jumping straight into one of the most time-critical situations in all of medicine, the initial management of an acute stroke. What you do in those first few minutes and hours is going to define your patient's outcome, so let's get you ready for it.
You've all heard this, right? Time is brain, and let me tell you, it is not just some catchy phrase. It's the absolute truth. With every single minute that ticks by, millions of neurons are lost forever. So our mission is to act fast and act smart to save as much of that precious brain tissue as we possibly can.
So here's our game plan for today. We'll start with the 4 core goals you need to have locked in your mind. Then we'll hit the basics, the absolute first response with the ABCs. After that, we'll walk through the rapid diagnostic process, get into the really crucial treatment decisions, and finally, cover the supportive care that has to happen all at the same time. Okay, first things first. The moment you suspect a stroke, your brain should immediately shift into a focused 4-goal mindset. These are the objectives that guide everything you're about to do. Think of it like this. Your first job is to make sure the patient is medically stable, that they're not about to crash. At the same time, you're looking for anything obvious you can reverse right away. Then, the big one, is this patient a candidate for reperfusion therapy? And finally, you start piecing together the puzzle of why this happened. These 4 goals are your roadmap through the chaos. Now, before we get too focused on the brain, we have to take a step back. The absolute, non-negotiable priority number 1 is the basics: airway, breathing, and circulation. The ABCs always come first. So what does that look like in the real world? It means getting a set of vitals like yesterday. If the patient has a decreased level of consciousness or can't handle their own saliva, you have to protect that airway. And yeah, that might mean intubation. And listen, this is a really important point about oxygen. You're going to monitor their saturation, of course, but you only give them supplemental O2 if they are actually hypoxic. We don't just put every stroke patient on oxygen anymore. It doesn't help if their sats are already good. Okay, the patient is stabilized. Now that diagnostic clock is ticking, and it's loud. We have to move through a very specific, very fast workflow to figure out exactly what we're dealing with.
And the first big question you have to ask yourself is this: is it really a stroke? Or is it one of the classic stroke mimics, something else that just looks a whole lot like a stroke?
Here are some of the usual suspects: a postictal state after a seizure, a really complex migraine, and especially a major swing in blood sugar, either way too low or way too high, can all present with focal neurologic deficits. This is exactly why we need a quick but smart workup. So here's your hyperacute evaluation in 4 essential steps. 1. Get the history. And you have to nail down the time last known normal. It's everything for treatment. 2. Do a standardized exam, and the NIHSS is the tool for that. 3. Check a blood sugar. It's the only lab test you must have before you can give clot-busting medication. And 4. Get that patient to the scanner for a non-contrast head CT stat. And speaking of the NISS, it's so much more than just a score. It's a language. It lets you objectively measure the stroke severity, and it lets you communicate that severity clearly to the neurologist, the neurosurgeon, or anyone else on the team. It's an absolutely fundamental tool. All right, so that non-contrast CT. This is the fork in the road. This is the image that changes everything. If you don't see any blood, you're dealing with an ischemic stroke, a blockage. But if you see a bright white, hyperdense area, well, that's blood. It's a hemorrhagic stroke, and the treatment path is completely different. So let's say the CT is negative for blood. We've diagnosed an acute ischemic stroke. Now we're at the sharp end of the stick, facing 2 massive decisions about reperfusion and blood pressure. First up is IV thrombolysis. The big question is, can we give this patient a powerful clot-busting drug, something like alteplase or tenecteplase, to try and dissolve that clot and get blood flowing back to the brain? And here are the big checkpoints you have to hit. You need a confirmed ischemic stroke with no bleed on CT, of course. The symptoms must have started within the last 4.5 hours. That's a hard stop. And you have to be able to get their blood pressure under 185/110. Plus, you have to run through a checklist to make sure there are no other major reasons they can't get the drug, like a recent big surgery. But what if it's a really big clot in a major artery? The IV meds might not be enough. That brings us to our next question. Is this patient a candidate for a mechanical thrombectomy? This is where we physically go in and pull the clot out. Now, this is a total game changer, but it's for a specific group of patients, those with a large vessel occlusion, usually in the anterior circulation. And here's the amazing part. The treatment window is way, way bigger. We can potentially do this up to 24 hours after the patient was last known to be normal.
Okay, let's talk about blood pressure because it's so important and a little counterintuitive. As you see, if we're given a clot buster, we have to keep that pressure down to reduce the risk of bleeding. But look at that last row. If the patient is not a candidate for reperfusion, we actually practice something called permissive hypertension. We let their pressure run high. We don't treat it unless it's over 220. The idea is that the high pressure might help shove some blood flow through smaller collateral vessels to the parts of the brain that are starving.
Now, while all of this high-stakes decision-making is happening, you can't forget about all the other stuff. There's a whole parallel track of supportive care that you've got to be running to prevent complications and give your patient the best shot at a good recovery.
So what's on that list? Well, you've got to manage their glucose. Both low and high sugar is bad for the injured brain. You have to keep them NPO, nothing by mouth, until they pass a swallow screen to prevent aspiration pneumonia. A fever is the brain's enemy, so you treat that aggressively. Keep the head of the bed up. And if they're not moving, they need DVT prophylaxis. All of these things are absolutely vital.
So we've covered a lot of individual actions, but one of the biggest points in the source material is about the bigger picture. It's not just about what you do, it's about the environment where you do it. The evidence is crystal clear on this.
Which leads us to this final, really important question. You can do every single step perfectly for your one patient, but what's the secret sauce that makes an entire hospital system successful at treating stroke?
And the answer is this: organized, multidisciplinary, dedicated stroke unit care. It's about having a specialized team, nurses, therapists, doctors, all working together, following proven protocols in a unit that does this day in and day out. That's what truly moves the needle on patient outcomes. It's the system that makes the difference.
All right, that wraps up our explainer on the initial management of acute stroke. So remember the key takeaways: act fast, be systematic, and work as a coordinated team, because that right there is how we save brain. Thanks for tuning in.